Hello, I'm Saul Wiener, and this is On Becoming a Healer. My co-host, Stefan Kertez, is not able to join us today. We do, however, have a wonderful guest who will be talking with us about a sobering but important topic in the training of physicians and the culture of medicine, which is medical student mistreatment. Now, there's a sad irony, as I see it, which is that on the one hand, medicine is a healing profession, and yet at the same time, we all too often harm our own. We don't know exactly what the incidence of medical student mistreatment is, although we have a pretty good idea that it ranges from somewhere between 25% and 75% based on self-report by students. Regardless, what we do know for sure are three things. First is that mistreatment is common, far too common. Second, it's an inequitable environment. Women, underrepresented minorities, Asian students, students who self-report as multiracial, and LGBT students seem to bear a disproportionate burden of mistreatment, as reported on a variety of surveys. And finally, I want to dispense with any myth that this is just a bunch of wimpy students who are whining. These incidents are often not minor. The AAMC collects data on 8 different types of mistreatment. They are public humiliation, physical harm, performance of personal services, sexual harassment, gender discrimination, ethnic discrimination, sexual orientation discrimination, and offensive behavior based on personal beliefs or characteristics. So medical educators around the country have been trying to tackle this problem for a long time. One brave study was published about a decade ago by a team at UCLA that reported on a 13-year effort that was multifaceted to address medical student mistreatment at their institution. And I say it was brave because they concluded that they had failed. And I don't think this is anything unique to UCLA. I think they were really speaking to something that is a national issue. So my guest today is Warren Wakeman. Warren is the Associate Dean of Clinical Science Education and Educational Technology, as well as Associate Professor of Clinical Emergency Medicine at the University of California, Irvine School of Medicine. Warren has been part of a group that has developed an intervention that we'll be talking about today to try to reduce medical student mistreatment in their College of Medicine. The conversation that we have will be both about this particular program, which is available to any of you, and also about this broader challenge of addressing mistreatment, which seems to be such a challenge for all of us who care about how our students are treated and the future of our profession. So, welcome, Warren.
Thanks, Saul. Really happy to be here and talk about a really important topic.
Yeah, so I thought we would start by discussing this initiative that your institution developed with funding from the American Medical Association. You came up with the app title, #MDs2, a student mistreatment prevention curriculum for faculty members and residents, which was published in 2020 in the Clinical Teacher, but is an ongoing program. So can you tell us first how you got interested in the topic of trying to address medical student mistreatment?
Absolutely. I think the credit should go to Dr. Convon Lee Buckland, who is our Vice Dean of Medical Education. And this really started out as a passion project and an interest on her behalf. And the timing was really great for this idea of hers to come to fruition. The AMA at the time had this grant, a call for grants, to really challenge these wicked problems in medical education. Looking for things that were really challenging that hadn't had great solutions. And so we put together this mistreatment curriculum really to help us figure out what's going on, right? As you said, it's pervasive throughout medical education. There are a number of different approaches. UCLA had an approach. Stanford had an approach. There were some great resources available at MedEd Portal, but no one had really put together, a fully comprehensive student, faculty, resident type curriculum. We wanted to tackle that.
So tell me a little bit about how you conceptualized the design of this program, what its basic elements are, how it works, and how you decided that it might be a good way to address some of the major drivers of medical student mistreatment.
Sure thing. I think with any topic like this, the last thing people want to hear about is a lecture or an online training module that says, hey, stop doing this, right? That's really not the most effective approach in doing it. And so we took inspiration from other curricula that were trying to change behavior and put this around a case-based discussion, right? In medicine, we love case-based discussion. And so we put together a set of videos that highlighted some pretty egregious examples of learner mistreatment and then some more subtle ones, right? And then that way you can have a sort of a good progression for your learners, right? Start them off with something easy and then work into more complexity and really highlight, what mistreatment is and how to identify it and give a better definition. And so within that, we developed this kind framework. It's sometimes hard to identify what mistreatment is, but using this kind framework, it's a 4-part component, and we're looking at, looking for activities that are missing in the interaction. Is there knowledge sharing? Is the interaction inclusive? Is the interaction non-discriminatory? And is it developmentally appropriate? Meaning, is it an appropriate interaction for, say, a brand new third-year medical student to be at that level of understanding? And when you miss one of those components, then it leans into mistreatment. So it gives a good framework, almost a checklist that faculty and residents can look at and say, oh, wait, this conversation doesn't seem to have one of these components. Maybe this is mistreatment. And part of that discussion, I think, too, is you alluded to this in the introduction, that this is so pervasive. Efforts haven't really had a huge effect. So what's happening here? And I think it's less of an individual choice to mistreat. It's sort of part of the culture of medicine. And, people don't like saying that it's part of the culture of medicine, but I think some of the behaviors and activities that we engage in are just things that we've seen modeled before. No one's really said anything about it. And it just becomes the norm, which is not a good thing. And so part of this curriculum was designed to kind of resensitize individuals to the fact that, hey, this is not appropriate anymore. What was considered okay 5 years ago, 10 years ago, 20 years ago, probably not okay today. And realistically, probably wasn't okay back then either, but the culture was kind of overlooked that back then. So we're trying to resensitize people to these issues.
Yeah, I remember when I was starting medical school, I think it was the first week or two, I already started hearing rumors about a particular physician who was notorious for being pernicious. And, then lo and behold, 2 years later, when I was an M3, I ended up getting this individual as one of my attendings. And yeah, he turned out to be just as bad as I had heard he would be. And it was really traumatic. One of the things I was thinking about as I was going to the hospital this morning is that when you walk into the hospital as a medical student, particularly at the beginning of your clinical training, it's just a frightening place to begin with. You walk in and it's such just the smells and the noise and the sense of your own ineptitude. And similarly, when you start as an M1, you've been spending so many years building up to becoming a medical student, entering this incredible profession, that, what you so desperately need is to be welcomed and to be supported. And then what happens, of course, all too often is something quite different. And, I think when I was preparing for this session to talk with you, I was looking at the literature, and this is so, as you said, this is so embedded in our profession. I even looked internationally. I pulled papers showing high levels of student mistreatment in developed countries, or articles coming from Sydney, Australia, from Japan. This is such a part and parcel of becoming a physician that, one has to wonder, what is it about the nature of our profession that this is almost inseparable from it? And I'm just curious if you have any thoughts about that. I mean, clearly we have to think about this, as you say, it's a wicked problem.
Right. I mean, it's hard to really kind of nail down. And we've thought about that a lot too. What is that core piece of it, right? And I think if you can figure out what that core driver is, it helps address the challenges moving forward. And it was really hard for us. I mean, a part of it, I think, is that desensitization piece, right? Again, this is more of almost a symptom of it, right? The fact that, one of the things we talk about is, performance of personal services. And then while that seems very vague, it's little things. It's sometimes considered scut work, or, when I was a student, it was considered scut work to grab coffee for the team or go pick up food for the team. And that was just sort of part of the culture. I remember as a student for that specifically thinking, well, that's your job as a student. At least when I'm a resident, I don't have to do that anymore. But at least I'm not an attending who then has to pay for all the food that people go and get. So there was that progression, and that was just the norm. And so then I think the resensitization helps, but how did that become kind of the norm in the first place? I think that's a tough question. I think there was also those discussions at the very beginning of, medical school, that it didn't happen at our program, but that thought of, look to your left, look to your right, one of these people won't make it anymore. That whole idea that even though you've excelled so far to get into medical school, that it's still hyper competitive, and it's still this almost an exclusive environment. I don't know if that breeds some of this, kind of type A mentality that makes the hierarchy even more ridiculous at times. And I'm not sure if those all contribute to it, but I wish there was a nice, easy answer. But I guess if there was, it would be solved.
For our listeners, you have a series of very short videos that are part of the curriculum. I can't recall. I think there are maybe 10 or so of them, one for each of the 8 major categories of student mistreatment. And then you have a few extras that show what good behavior would look like, that sort of model the opposite. And one of the pairings, it has to do with personal services. And in one example, in the bad example, the mistreatment example, you see an attending and 2 residents, and essentially one of the medical students, an attending and 2 medical students, and one of the medical students is basically told to go, buy a bunch of food and stuff. And this is going to be instead of getting to present their patients in round. And the attending sort of implies that it's fine to do this because the attending is going to pay for it anyway. And so the idea is, well, as long as I'm paying for this, or I'm giving you my badge so that you can go to the cafeteria and get this food, it's I'm not abusing you because, you're not going to have to pay for this food. But in fact, what you're doing is you're telling the student, instead of learning and being on the team and getting to present your patient, you're going to go off and get food for us. And that is obviously disrespectful. It's a misrepresentation of our role as attendings and supervisors. And then what was interesting is in another video, you show a situation where an attending is asking a medical student, I think, to go off and basically track down the medical records of a patient who has gotten care from another hospital. And the point is that that's fine. That is part of being a doctor, so that when you're asking a medical student to go and look up stuff that requires a fair amount of paperwork and, going off and trying to chase something down, if it's for the purpose of patient care, then that's part of training someone to be a physician. But if it's to get coffee and donuts and stuff like that, then that becomes a problem. So I think one of the things that came out of what I read from your paper is that sometimes attendings aren't quite aware of what constitutes mistreatment and what isn't. And similarly, students sometimes aren't aware of what constitutes mistreatment and what doesn't. And one of the things that came out in your pre versus post survey was that there were a number of, and this happened pretty much over and over again, that there were always a significant number of participants, attendings, residents, who didn't realize that they had been mistreated before they went through your curriculum. And then afterwards, and they were asked to reflect back, they were like, oh yeah, I guess I was mistreated. And so I think, of course, if you're not aware that you've been mistreated, first of all, that raises important questions about your understanding of what it means to be a student and a learner, but it also means you may be more likely to repeat those things when you're in charge.
Right. And I think it was really interesting going back to that first video where we're talking about, having the student go get food for the team. We wrote that with an attending, a resident, and a student. And one thing we didn't intentionally write in the script, and maybe I'm giving this away, but someone later on found out, or as they were watching the video, they said, well, isn't it interesting that the resident, instead of standing up, they're just kind of going along with it and they throw in their food order as well. And I thought, well, yeah, that actually makes sense because at the very beginning of our talk, we talk about the cycle of sort of desensitization, right? As a student, you get mistreated. It continues to happen. And without intervention, sort of passively, it becomes just part of the environment, part of the norm. Then you're a resident. It may not happen to you, but you see it happening to students. And you don't really say anything because it's just part of the norm that you've seen. And then you're an attending and you think, hey, I'm hungry. I've got 10 students on the team. Let's go send a couple of them to get food, right? So it becomes this continuous cycle. And even though we didn't intentionally write the resident role in that case to go along with it, I think that's almost telling, right? That by default, the way the scenario was written was that the resident goes along with it. So there's a little bit of that just, for me, even just, I was desensitized to it even in the writing of the script. And it turned out to be very fortuitous because people would call it out as they're watching the video saying, hey, the resident could have spoken up as well. And so it really brings that home that it's really embedded in there. And even as you're trying to write a case to highlight negative behavior, there are things that we missed, right? And I think that's part of this continual improvement and soliciting new cases and new ideas, because there are other things that I might not be aware of because I have my own blind spots. And having multiple people contribute really helps make this a more robust curriculum.
Yeah, again, just to clarify, because I don't think I had it quite right. In the scene that you're describing, there's, as you said, a medical student, a resident, and an attending. And I think what you're getting at here is that the medical student gets sent off to get the food instead of being in a learning situation, and the resident kind of buys into it and starts piling on requests for food and so forth. And then the attending says, oh, I'll pay for it. So it's, as you said, it's almost like an intergenerational process. And those of us, people like you and I who care about mistreatment, we can become blind to those same behaviors ourselves because we've been embedded in the system for so long. And I think that's your point.
And I think it's important too from, when we work with faculty and residents, if you look at the mistreatment numbers that are collected in the AAMC's graduation questionnaire, most of the mistreatment is attributed to the clinical years, more than the classroom time. And it's often, the majority of it is put on faculty, and then residents are sort of that second category. And then surprisingly, a mix of students and nurses are in the third category. And so while residents and faculty play heavily into this, it doesn't mean that all of them are going to mistreat. And I think there's a really important role for them to play especially as you go up in the hierarchy that is medicine, of looking out for it and intervening. So you may be a faculty that is now sensitized to this, and you see a resident sending a student off to do something, or a resident's mistreating a student. That's a perfect opportunity to intervene. And as a faculty, you shouldn't feel nervous about intervening. A lot of our learners worry about speaking up for fear of retaliation. I want to go into surgery. I saw some mistreatment on a surgery rotation. I don't want to speak up, or on emergency medicine or on medicine, right? But as an attending, you don't really have that fear anymore. You shouldn't have that fear anymore because you've made it to that degree of your career. So it's really also a call for both our residents and our faculty to speak up more at times when students feel that they don't have a voice.
Yeah, now I saw in the literature, and actually we had an earlier podcast episode on professionalism, which bears some overlap to this one, in which medical schools have built surveys into the system that students complete, in which they're asked to comment on, and they do it anonymously, but on attendings who have behaved in ways that are highly respectful, and implicit if they rate them very poorly that they haven't. And the wording of these surveys is important. I don't have it on hand, but in the one we did on professionalism, where they were trying to identify a small cohort of attendings who were not behaving professionally, they found that no attending wanted to get low ratings that are publicly available, that indicate that they're not behaving professionally or respectfully towards their team. And so they found that just by instituting an anonymous survey where the students or residents who completed are anonymous, but the name of the attending is accessible at least to the dean's office, that quickly reduced the problem, that the number of attendings who were being identified as unprofessional just dropped. The problem was corrected very rapidly. And I think some of the same techniques have been used around mistreatment. I think I saw a paper from Stanford, for instance, where this had been done as well. So I'm curious about your familiarity with this whole issue of using surveys to try to discourage mistreatment.
I think it's an important piece, right? We've seen how well those physician surveys work when it comes just to patient satisfaction. And I know that there are challenges with things like Press Ganey and other metrics, but institutions that have really gone for a full transparency approach to physician feedback and rating have had at least the outcomes that they're looking for. And I think that can work well with mistreatment, with our faculty, I think it's important to both reward the faculty that are absolutely great with our students, and then for faculty that have identified as having challenges with students, it's really important to help them get better, right? And I think, as we were talking about earlier, it may not always be, their behavior is not really always driven out of malice, right? It might just be out of, they just don't know. And to a certain degree, that excuse only goes so far. But I think once your behavior has been identified as not being appropriate, it's on you to make that change. And so one of the things I think that's important that we tell our students as well as our residents is that by reporting mistreatment, the intent is not to get the faculty fired, or getting them kicked out of the institution. The importance of it is to, one, identify that there's a challenge that they're having, a problem that they're having, and then how do we address that? And like anything, there's always continual learning. We all have these blind spots, even if we've been practicing for 10, 15 years. And if the students can assist a faculty in getting better, that's a great thing to do. So we really want to try and encourage that as a reason to report, that it's not meant to be, a complete disciplinary action. It's also meant to just make them aware that, their behaviors are not really considered appropriate anymore.
Yeah, I think like everything else, these problems fall along a continuum. So I think that maybe it's a majority of faculty where there are mistreatment issues that they're just not aware of what's happening, or they've been conditioned to behave that way based on how they were treated, haven't given a lot of thought, the kind of thing we're talking about now where you send somebody off to get food. But then, of course, there are the more pernicious situations where power, kind of power is involved and somebody's being put in their place. And I also, and again, this is entirely my own opinion, but looking at the literature, I do feel like there's a kind of internalized misogyny in the profession of medicine. Medicine used to be an all-male profession. Power has always been, and hierarchy have always been very much a part of that environment and that culture. And even though there's been substantial diversity in medicine now, of course, it's almost 50-50 male-female. We now have underrepresented minorities. We have a whole diversity of physicians and students coming into medicine. Some of the culture is still there. Perhaps a lot of the culture is still there. And I think that might be in parcel of it. I mean, when I look at, for example, we talk about, we always used to talk about the male boss who would send his female secretary off to get coffee for him, that kind of thing. And that now is, the attending who may not even be male, may be female, but who has kind of internalized the culture and is now sending off students to do things that are not really part of the learning experience. Now, I think it's important also to point out that what we're talking about in this example, it may not sound like such a big deal, but it's really part of a whole pattern of mistreatment in the videos that you guys created, which, by the way, I think are fantastic. And hopefully we can share a link to all of them with our listeners. They're very brief videos. They're literally like 2 minutes each, but they're really good. And they're all based on real scenarios. And they range and they cover each of the 8 areas of mistreatment. And so, for instance, one of the ones that I think illustrates, I guess, what would fall under some form of sexual harassment is really something when you watch it, you're like, oh my God, I could see that happening so easily, which is that you see a student or a resident, I think it's a student on one side of a patient in a procedure room, and then the proceduralist, the attending, who might be a surgeon on the other side. The surgeon's trying to give instructions to the student about where to position themselves, and the student's having a hard time understanding it. And then somebody else walks into the room. It wasn't clear to me whether this was another attending or a technician or whatever. And this is a male who walks in, and the student is a female. And the male grabs the student's hips, basically, and starts like moving them around, basically saying, no, this way, no, that way. And they're literally holding this person around their hips. And you can tell that the student who's gloved and gowned is extremely uncomfortable with what's happening to them, but doesn't know what to say, and it's just so awkward. And I'm assuming that you probably took that from a scenario that someone passed on to you.
Right, and it's those sort of environments that, again, especially in those procedural settings where you're gloved and gowned and sterile, and it's hard to move around. That's where we've heard anecdotes from our students. We've heard anecdotes from our residents and faculty recalling there are times when at that point someone put their hand on their hip or hand on their shoulder, and the hand kind of lingered there for a while, and it was really awkward. And then later on they found that faculty member, that's their MO, especially in those environments. And so it's that pattern of behavior. I think that there are those occasions where there might be an individual that has 1 or 2 incidents and they mess up, but oftentimes for these people it's more than just them being desensitized to it. There's a pattern of behavior there, and it's really important to highlight that we could probably go right now to any one of the medical students, and as you mentioned before, there was almost that urban legend or lore of watch out for this faculty or watch out for this resident. And even today, I'm sure if you went to any medical student at any medical school and said, hey, is there a resident or surgeon or internal medicine doctor or ER doc that we should watch out for when we're in the hospital, they'd probably be able to give you an answer like, oh, I've heard about this person, right? So that still exists, right? That hasn't gone away, that people have a reputation that precedes them. And those are the activities, those are the behaviors that we want to try and capture, highlight that that's not appropriate. And even though it seems like nothing, oh, I just, grabbed by the hips and moved over, it's still a violation of someone's space and taking advantage of them in a sterile situation where they can't do anything. And it's really important to call out those behaviors as well.
Yeah, watching it, I thought the acting was great, but I think it captured, just looking at the situation that this student was in and looking at her face, first of all, this sort of bewilderment of like, is this supposed to be happening, right? You remember when you're a student, you're in a new environment, you don't even know what the culture is. You're like, I'm being moved around physically by this guy who has his hand on my head. Like, is this normal? Maybe it's normal. I don't know. You almost get that look. And then at the same time, what is she going to say anyway, right? That she's in a situation where she's going to be graded. She's already being slightly berated. It gave you a real sense of how trapped somebody is in a situation like that, where they really just don't have a lot of options.
And when we've talked to the students and residents about that, the ultimate next question that comes out of a lot of these incidences are, well, what do you do as a student, right? You're obviously sort of at the lower part of that power dynamic, and that's a situation that is hard to break out of. And we've heard residents tell stories of when that happened to them, they would intentionally contaminate themselves so they'd have to scrub out. And they'd get a little bit berated. Oh, look at you, brand new resident, don't know how to maintain sterile scrub, but at least they did that so they can get out of that environment. And some of them highlighted that they had, the other faculty in the room or a really great nurse or scrub tech saw that and said, oh, I think you might have violated, the sterile field. I need you to go scrub out. So they caught that behavior and they removed the student or the resident from that environment. So, it's really about being aware too as a bystander and what you can do to sort of safely extricate an individual who's in a bad situation, and how do you make that happen?
Yeah, at my own institution, we found that when we compare what's on the AAMC graduate questionnaire to what students are actually reporting, they're grossly underreporting. And so the question, of course, is why? Why is it that they're not reporting the same incidents that they are recording anonymously on these surveys? And I'm assuming that it must be at some fundamental level because they don't feel confident that it isn't going to come back to bite them in some way. I'm assuming that might be the most likely reason. But I don't know. Is that something that you've seen? What are your thoughts about that?
Yeah, the underreporting, it's a little frustrating from our side. How do you get that reporting up? And that graduation questionnaire, it does ask, if you didn't report, why didn't you report? And I was just looking at that data before this call, and kind of nationally, about half the students responded that they didn't seem it was important enough to report, which, is that just the culture setting in that, mistreatment's okay, doesn't need to be reported, but we need to know that it happened. It's a sort of a weird answer in my mind. It didn't seem important enough to report, but you reported on the questionnaire, but how come you didn't report it in real time? And then the next biggest group was, I didn't think anything would be done about it. And that's, that part's while the first question, raises more questions, the second one, it saddens me a little bit that, that they don't have faith in the institution, just nationally, that they don't have faith in the medical education leadership to make that change. I have noticed, though, that, in dealing with a lot of these issues, that we get reports of mistreatment, being able to close that loop of communication with the students is extremely challenging. And, if a student reports, misconduct by a faculty member, there's not a good way to report that conduct has been addressed, right? We can say, we have a mechanism to go through the department and talk to the chair and the program director if it's a resident, and how to do that. But whatever that resolution is, we don't send out a mass email to all the students and say, hey, we heard that so-and-so was problematic and this is what's being done. So we don't have a nice mechanism to do that. We're hoping that, the behavior changes and there's no further behavior. But for a lot of things that our students are used to reporting and asking about, we can give them very clear feedback as to what's happened. But when it comes to mistreatment, there's not a good mechanism for us to do that. And especially when you get into things that fall under, sexual harassment or discrimination, those are often handled by the Office of Equal Opportunity and Diversity, OEOD, and those they handle almost entirely. And there's not a good feedback there either. And sometimes we don't even hear as faculty what remediation or the result of their investigation, because it's with that individual or maybe that department's immediate supervisor. So there is that gap there that I don't think that completely explains why the students feel nothing will be done about it. But I know it's a big sort of systems issue we have to look at.
Well, and again, this is just my opinion because we don't have data, but I'd be inclined to agree with the students that all too often nothing will be done about it. I think that prevalence of this problem is vast. It's happening all the time. And, and quite honestly, I mean, as you point out, when a medical school does take action, even if it's positive action, they just meet with a faculty member in a positive way, it's hard to report that back to the student. But I mean, quite honestly, how often is that? What percentage of the time is that happening? I don't know if your system has a watertight approach to following up on every mistreatment episode that's reported. Do you?
We do. Whenever we receive a report, we keep track, at least for our purposes, to make sure that it's being addressed with the appropriate parties. Now, I think there is that gap, though. Like, sure, it's addressed. There's a sit down. There's a discussion that happens. But then what, right? Is it a unilateral discussion? Is it what is the action and then what is the end result of it? I think that's the bigger part. So there is that big gap. And I think
Mhm.
to your opinion, it's true. I mean, if you look at those kind of national numbers, right, depending on the study, it's anywhere from 20 to 75%. It looks like over the past at least 5-6 years or so from the graduation questionnaire from the AAMC, that number overall sits around 40%, and it's been relatively, in that pocket for the past 5, 6, 10 years or so. So even if these things are happening, one, are we addressing it so well? But then are new people coming in that are mistreating students? So there's always this kind of steady state. Why is there this steady state still despite all of these interventions? And I think that's the big challenge too, right?
Yeah. It's interesting. We've been talking a lot about how to respond to mistreatment. But of course, what we're also trying to do is create a culture where it just wouldn't be part of the culture in the first place. And that's the much more challenging issue because we're getting to the whole question of our profession. As I said at the beginning, there's this great irony that medicine is supposed to be about healing, right? It's a healing profession. And how ironic that we harm our own. And that it just implies that there's a revolution that hasn't happened yet that needs to happen in the culture. And again, I keep falling back on this idea that this is a historically misogynist profession, right? It was all male, highly power-based, highly structured, around power. And this is part of its international milieu. It's not just American medicine. And so, we have to have, in some ways, we have to have a really difficult conversation about our culture and what it means to be a physician and to be an educator and to be a teacher and the culture of that. One of the things that I felt is a form of mistreatment in our curriculum that actually doesn't fall into any of these 8 categories. And again, this is my opinion, is the curriculum itself. And what I mean by that is, I've talked about on this podcast how I'm learning disabled. And so when I started medical school, the M1 year was just particularly torturous for me because I was slammed. I mean, everybody's slammed. I was just overwhelmingly slammed. But it made me hyperacutely aware that I was being asked to memorize all kinds of stuff for short-term recall on tests that I could look up that I didn't really need to know. I remember having to learn the 16 types of collagen. And, actually, there were only 12 types of collagen then, but now I think there's 16. You know what I'm saying, that the profession, it keeps growing. But I do know that they're still asking students to do stuff like that. Some of it they may have to regurgitate on the USMLE exam. Some of it isn't even on that. And either way, it's stuff that, you wouldn't necessarily prioritize for an M3. And then you arrive at your M3 year, and then you realize you haven't learned the stuff that you actually need to know to be a doctor. And
Right.
I remember when I was in M1, I had we were assigned like mentors who were like 3 years ahead of us. And I remember my mentor, I think she was an M4 and I was an M2 at the time. And she was like, I don't mean to demoralize you, but you may as well have been reading Charles Dickens for 2 years because quite honestly, when you show up on your clerkship, it's going to be completely bewildering. And of course she was right.
Right.
And yet I had, busted my butt for 2 years working so hard. And then I got there and I realized that, I'd spent, 80 hours a week or whatever, learning a bunch of stuff that I was going to forget. And it wasn't even the right stuff a lot of the times. And so, this gets a little bit hyper intellectual, but I had an earlier podcast episode where we talked about the philosophy of Michel Foucault, who talked about how sometimes knowledge is used as a form of power. And that, when you're spending all of your waking hours kind of at the mercy of a bunch of professors in biochemistry and histology and pathology and anatomy who can throw anything they want at you and you have to spit it back, is that a form of mistreatment? And in many ways, that is the dominant culture of the first 2 years of medical school. It's studying and learning and doing whatever your professors ask you to do. And so I was just struck by that. I know I'm kind of throwing a curveball at you because it's not one of the 8 forms of mistreatment, but I'm just curious about your thoughts.
No, I mean, it's you bring up really interesting points because there is, I think, in that traditional 2+2 model, there is a big disconnect between a lot of the content that is taught in the first 2 years and what's really relevant in the clinical part. And I think a lot of it is, what does a practicing physician need to know in this area? And it's really important, I think, to have a strong foundation, but I think at times that can be used as an excuse to really dive deeper than what may be practical for most practicing physicians. I think the good thing that we're seeing now, a lot of schools are adopting this kind of shortening of that pre-clinical, that pre-clerkship, that basic sciences curriculum as low as 12 months to 14 months. And we're seeing a lot of schools moving that clerkships into the M2 or their second year. So they have a year of foundational content. They get into the hospital really early. So now they have a better context for where all this happens. And so then they start spreading out more of that basic science content so that it's more relevant, because now you're seeing patients and now you know what is important. And I think a lot of those programs that are doing that, I think, are helping kind of move in that direction to giving clinical relevance, which is really what we're practicing for. I think there's also the big pushes we've seen with schools going pass fail instead of having, honors pass fail or grades. We're seeing that with USMLE 1, step 1 going to pass fail as well. So it's not about a numbers chase anymore, which I think was a big driver of those first 2 years. Having a single test that determined what specialty you're going to go into at times is a little bit overwhelming for a student, especially if you're not even in the hospital and you might change your mind, right? So
Yeah.
I think these are big transition points that we're starting to see on that curriculum level. And I think also, to your point about, thinking about diversity, we're still overall, we're getting better, as having a diverse medical student and physician workforce. When we think about all of the dimensions of, race, ethnicity, sexual orientation, we're getting better there. The one area that I feel like that we're still less prepared for are individuals that have, learning challenges, right? Or physical limitations. That's another area of diversity that a lot of schools just aren't as well prepared for. And so when we start thinking about expanding diversity or thinking more about diversity, we have to think about that aspect as well in our students and future physicians.
Yeah, and I think that the way in which you're expanding the conversation with your comments about going to pass fail and addressing diversity and making the environment more hospitable for people who are differently abled and so forth, I think that should be part of the conversation around preventing mistreatment, because it's all part of the same culture. And I think that, one of the ways you show respect to your students is by being highly attentive to what you ask them to learn, right? Because when you ask them to learn something or to memorize something, you're asking them to commit to doing whatever they've been told because they don't have any other choice. And you're taking away time that they might have been able to use for something else. And so I think it behooves us to make sure that we have thought very respectfully about why we think it's important that they put this effort in and how it's going to make them a better doctor. And I think that's part of preventing mistreatment. I think that when we don't do that, when we don't show respect and we just throw telephone books at people and ask them to memorize them, that's not respectful and it's a form of mistreatment. I think that making something pass fail when there's no reason to create the pressure and tension of a curve or that's showing greater respect. I think when we modify the technical standards for entry into medical school, as you were alluding, so that individuals can come who are differently abled, that's showing respect for future physicians. And so I think that we really need to connect this conversation about mistreatment to this larger question of how do we make medical school a place where we're cultivating the next generation of physicians who are our junior colleagues, and that covers the whole gamut of the experience that we create for them. So I think I agree with you. I think that should be part of the larger conversation.
Right. And maybe that's the piece that we're missing, right? A lot of schools have tried to tackle mistreatment specifically, and you see some immediate successes, and then UCLA showed in the longer term maybe the success kind of evened out, right? And maybe that's the piece that's missing, that while we can resensitize individuals to the actual mistreatment, it's that culture that underrides this. That's the secret sauce that we've been missing, so to speak, over the years. But I think that schools are making these changes, I think, for the better. And it's one of those things, unfortunately, that we're not going to see the benefits pop up in the next year. We're not going to see it on a single survey. This has been part of the culture for a very long time. And while I think we all want a quick resolution or improvement, it is going to go slow, but I think it doesn't stop the importance of making these larger kind of holistic changes too.
Yeah, and I think that might be the solution to this much larger question of how do we fix this wicked problem. When I was planning for this podcast episode, I was thinking to myself, how are we going to wrap this up? And I couldn't come up with a way to wrap it up because we don't really have answers. And again, I come back to the UCLA study. And again, I'm not picking on UCLA. I think it was emblematic of the whole country. But they tried to do everything right. They had committees, they had policies, they had easy ways to report, and yet they weren't able to move the needle. In your program, you haven't tried to collect that level of data. This is just an intervention that makes sense and that is likely to be beneficial, but you weren't trying to do the kind of global multi-year data collection that they did. But I was asking myself, what is it that they didn't do? And what they didn't do is address this much larger question of this whole culture in which we're cultivating the next generation. And I think that's really where this conversation has to perhaps end, because we don't have a simple way to tie this up with a bow. So, Warren, I want to just ask you how people who would like to learn more about your curriculum and maybe have access to these videos can do that. And we can always drop links into the show notes.
Perfect. Yes, we as we mentioned at the beginning, fortunately, this project was supported by an AMA grant. And so we'll have to include the link, but there is a website that has a list of all of our cases for review. There is a publication that we had in the Clinical Teacher that really talks about how we put together the program, some of the data, and that includes a link as well. And I think for this to be successful, it's really about starting the conversation. And I know some schools have had limited success in doing that. And these are an easy way to start with your faculty, with your residents, even with your students. I think it's important for them to sort of see what is being done to address this with faculty and residents. And the one area that we didn't even really get a chance to talk to is I think that we're very focused on physicians, residents, and students. That's a small part of the healthcare team. And our students and our learners interact with all sorts of other individuals, which we've heard, similar stories about, watch out for this nurse and watch out for this individual. So I think if we really, really want to address the problem holistically, there is the curriculum part, creating a more diverse across all dimensions workforce, but then also thinking about all the other people that we interact with, right? We're really trying to emphasize interprofessional education. So I think, thinking about learner mistreatment should also include a lot of these interprofessional groups as well. We're starting to see more incidences with patients. And so how does that play into this too? And so we're trying to tackle a small piece of the puzzle, but I think it's just a very small piece. And recognizing that there is more that we all need to collectively do is a really important next step.
Yeah, and I will I'll post in the show notes a link to an article in JAMA Internal Medicine that came out in 2020 called "Assessment of the Prevalence of Medical Student Mistreatment by Sex, Race, Ethnicity, and Sexual Orientation." It's a national analysis of data from the AAMC graduate questionnaire. And it does include, as you said, porting that's coming from experiences with nurses, other health professionals, as well as with attendings and residents. And so that'll be useful. I'll also include a link to the hashtag MDs2 paper that you wrote, and then and I'll also include a link to the academic medicine paper that described the study called "Eradicating Medical Student Mistreatment: A Longitudinal Study of One Institution's Efforts," and that was at UCLA. So are there any final thoughts or comments that you'd like to contribute, Warren?
Now, this has been an outstanding conversation, and we're really happy that the work that we've done, we have a really great team of Dr. Lee Buckland and Dr. Yum and McCrae and Osborne, that the work that we've done here resonates with so many other people and has garnered interest. And I'm glad that our little project could inspire others to hopefully tackle this challenge as well.
Okay, well, thank you, Warren. And we appreciate everybody's interest today. And take care. We hope you've enjoyed this latest episode of On Becoming a Healer. If you have, and you haven't already subscribed, please consider doing so now. Take care, everyone.